Okay, we're going to start with medications affecting urinary output. This is chapter 18. So the objectives, we're going to explain the role of the kidneys in maintaining fluid and electrolyte balance, compare and contrast the loop, thiazide, and potassium-sparing diuretics, explain the pharmacotherapy of sodium and potassium imbalances. For each of the classes, identify drugs and explain their mechanisms of action, drug action, primary actions, important adverse effects, contraindications and precautions, and interactions. Okay, looking at the kidney here, you have your urinary system. When we talk about loop diuretics, they're at the bottom where it has, on B, where it has the nephron tubule. Right there, the loop of Henle, that is where the loop diuretics work. The rest of them will work on the distal, the proximal tubules is where that will work. You don't need to know the flow of the urinary system. So that's about what I want you to understand and know is where the diuretics are called what they are due to the main one is just the loop diuretics. It's in the loop of Henle. Okay, so we'll talk about the loop diuretics first. The drugs are your furosemide, bumetanide, which is Bumex, and then Lasix. So they, once again, the action, the loop of Henle. Blocks the reabsorption of sodium and chloride. It prevents the reabsorption of water. So if it's blocking the sodium, then the sodium is being lost. And as we know, water follows sodium. So then that's why the fluid or volume goes down. Diuresing with severe kidney impairment. Therapeutic uses of pulmonary edema, edema due to liver, which is ascites, cardiac or kidney disease, and hypertension. Typically with hypertension, diuretics are usually the first thing that the physicians will prescribe as first-line treatment for hypertension. Complications can be dehydration. So we need to monitor for signs and symptoms of dehydration. So we're looking for the dry mouth, increased thirst, minimal urine output, obviously some weight loss. Also hyponatremia, so we're less than 135. So normal output is 30 mils per hour, so anything less than that needs to hold the medicine and report it. And then hypochloremia, which is low chloride as well. They're losing the chloride too. So monitor electrolytes for sure. Hypotension. Let's go back up. Under the dehydration and hyponatremia. If a headache or if they complain of a headache or chest pain, calf or pelvic pain, notify the provider. Because then we possibly are looking at a thrombus or an embolism. And then these patients need to be weighed every day. Hypotension, make sure they just change position slowly. If they get lightheaded, they need to sit back down. And then elevate the head slowly before getting out of bed or walking. Ototoxicity. This is more transient with furosemide, and it is, it can be concurrent use with other auto medications, such as aminoglycoside antibiotics, which is gentamicin. So if they start having tinnitus or ringing in the ears, then they need to make sure that they notify the physician, because that could be an indication for ototoxicity. Hypokalemia. So this is the biggest one I want you guys to really hone in on any diuretics is you're really looking at that potassium, because as we have talked before, remember potassium affects a lot of things as it comes to heart. It can cause dysrhythmias, so we need to keep a close eye on that potassium. So hypokalemia is below 3.5. Remember, your normal is 3.5 to 5. So we need to definitely get a baseline and then monitor it throughout therapy. So these clients can consume high potassium foods, bananas, potatoes, dried fruits, nuts, spinach, citrus fruits. And then things that they're looking for hypokalemia, nausea, vomiting, fatigue, leg cramps, that's going to be a big one, leg cramps, and your generalized weakness. Other things that can occur, hyperglycemia, hyperuricemia, which is high uric acid. And we got to watch people that have gout because they already have high uric acids. Hypocalcemia, hypomagnesemia, decrease HDL, your high density lipoprotein, so your good cholesterol, and then it increases that low density lipoproteins, which is your bad cholesterol. So we need to monitor all of these labs plus the glucose, and then anything that is out of range, they need to make sure that it gets reported to the doctor. When you're thinking of magnesium levels as well, symptoms of low can be weakness, muscle twitching, tremors, is what you're looking for and telling the patient to look for. Okay, these are contraindicated in pregnancy. Unless they are absolutely necessary, these should not be taken during pregnancy. Anuria, which is no urine output, is definitely contraindicated with this medication. Precautions: cardiovascular disease, diabetes mellitus, dehydration, electrolyte depletion, and gout. Which we talked about. The reason for gout is because the uric acid can be low, as well as all your electrolytes you need to keep an eye on, because once again, potassium is the biggest one you want to pay attention to. Clients are taking digoxin, lithium, autotoxic medications, NSAIDs, hypertensives. They just need to just be cautious with those medications. Interactions can be with digoxin. Oh, I'm sorry. These are all the interactions. Antihypertensive, lithium, and NSAIDs. So, nursing considerations, we've talked about a lot of this already. Obviously, you're going to get a baseline blood pressure, weight, electrolytes, and then make sure that there's not any edema that is already occurring. Weigh these patients daily, same time, same clothes, same scale. Monitor the blood pressure. Avoid administering these late in the day so that the patient's not up all night with nocturia. So dosing is typically used between 8 in the morning and 2 in the afternoon. It's just going to depend on your facility as well. Monitor EKGs if your potassium is below 3.5. Instruct your client to manage their hypertension and self-monitor their blood glucose or blood pressure and weight, and keep a log on it and have them bring that to the physicians to their appointments every time. Make sure they're changing positions slowly, and then just have the client report any significant weight loss, lightheadedness, dizziness, GI distress, or generalized weakness, because remember, that can be an indication of hypokalemia. Some of that is hypomagnesium, and hypovolemia, which remember is low fluid volume. Lasix can be given to increase urine output even when the blood flow to the kidneys is diminished. They can still use Lasix to help achieve those goals. If your client already consumes a lot of foods high in potassium, don't tell them to increase their potassium even more. Just maintain what they're eating and just see how their lab work comes back. Monitor blood sugars, the people that have diabetes, and then magnesium, looking for those signs and symptoms of low, weakness, muscle twitching, tremors. And then calcium can be the muscle twitching, muscle cramps, tingling in the hands and feet. And then autotoxicity, the hearing loss, or tinnitus. Thiazide diuretics, this is microzide, which is hydrochlorothiazide, HCTZ, which is probably what many of you have heard it by. These are also potassium wasting medication, so another one you have to watch. These work on the distal convoluted tubule. It once again blocks the reabsorption of sodium and chloride and prevents the reabsorption of water at this site, and it promotes diuresis when the kidney function is adequate. Therapeutic uses, essential hypertension, which we talked about, edema from mild to moderate heart failure, and liver and kidney disease. Once again, diuretics not only are a first line treatment for hypertension, they are also for heart failure. Blood pressure control, reduce urine production, promote reabsorption of calcium, and then reduce the risk of postmenopausal osteoporosis. Okay, so primary and essential hypertension classification. So the difference between the two, primary or essential, is going to be, this is 90 to 95% of your clients that you will see. They don't know why that they have hypertension. It's no known cause. A lot of times it just occurs. Versus your secondary is that other 5 to 10%, and this is caused by some other condition that is going on within the body. So kidneys, arteries, heart, endocrine system. So this would be one that would be considered for kidneys, because a lot of times with high blood pressure, if they have unexplained hypertension, then a lot of times they'll go down for kidney studies, ultrasounds of the kidneys to make sure that they're functioning properly and that they've got good blood flow and they're excreting the way that they're supposed to be. Otherwise, if they're not, then this would be a secondary condition to the for the hypertension. Okay, complications can be dehydration, hypernatremia. So once again, looking for those signs and symptoms of dehydration: dry mouth, increased thirst, minimal weight or urinary output, weight loss. Monitor electrolytes and weight. So remember what we're looking for: potassium, sodium, chloride. And then making sure that they're getting adequate urine output. So if it's less than 30 mils an hour, then it needs to be held the medicine and notify the physician. Hypokalemia and hypochloremia. So we need to know cardiac status. So getting a baseline EKG is not a bad thing for these patients that are getting started on this medication, especially the ones that are taking digoxin, which is very rare anymore. That was the old school use. They found better, which we will talk about, ACE inhibitors and beta blockers and all that they use a lot more now. And then report a decrease if the potassium level is less than 3.5, then you need to report that. Consume foods high in potassium. So once again, remember what your signs and symptoms are: hypokalemia, nausea, vomiting, general weakness, fatigue, and leg cramps. Hyperglycemia, so making sure that people with diabetes are monitoring their blood sugars. Hyperuricemia and hypomagnesia, increase in LDLs, so monitoring that uric acid, magnesium, your cholesterol levels, period. And then magnesium, remember the weakness, muscle twitching, and tremors are your signs and symptoms of low. Contraindications: pregnancy and breastfeeding as well. And then kidney impairment is contraindicated for taking thiazide diuretics. Clients who have cardiovascular disease, diabetes mellitus, hypokalemia, hyperlipidemia, hypomagnesia, or gout should be cautious with these medications, as well as if they're taking digoxin, lithium, and any antihypertensives. And then your interactions are the same as your loop diuretics. So overall, for both classifications, loop diuretics and thiazides, nursing considerations: you want to avoid administering PO diuretics. Okay, that first one should not say avoid administering PO diuretics. That one is the thiazides are the only ones that have to be given PO. There's no IV source other than chlorothiazide is the only exception. Monitor electrolyte levels, so your magnesium, your sodium, potassium, chloride, uric acid, blood sugars. Having the patient keep a log of blood pressure readings, weight, blood sugar readings. They need to report any of those signs and symptoms of low potassium, magnesium, and calcium. And then reporting any of those hearing loss or tinnitus with loop diuretics. Then you have your potassium-sparing diuretics, which is spirolactolone or aldactone. These are not wasting, so they retain their potassium. So this blocks the action of the aldosterone, the renin-aldosterone system. Therapeutic uses: hypertension and edema, managing heart failure, and therapeutic effects takes anywhere from 12 to 48 hours to start seeing those effects. Complication is hyperkalemia. So remember, now we can go the opposite way of being high. So especially if you have ACE inhibitors, angiotensin receptor blockers, which is your ARBs, and your direct renin inhibitors require caution because these can elevate the potassium level even more. So this would be a potassium greater than 5. Once again, hyper is weakness, fatigue, dyspnea, dysrhythmias. You need to treat it by withholding the medication and then restricting any potassium that is in food. And then we need to give them a diuretic of some sort to get rid of that potassium. And then we can prescribe glucose. A lot of times doctors, when I worked the floor, they would prescribe glucose, regular insulin, that we would actually give IV to help this drive the potassium back into the cells. And then we're not going to give obviously any supplements for this versus your other loops and your thiazides. They need to be on a potassium supplement. Endocrine effects: males are deepened voice, impotence, females menstrual irregularities. So just have them report any of those signs and symptoms. Contraindications: hyperkalemia or other potassium-sparing diuretics. Severe kidney failure and anorexia. Precautions are kidney or liver disease, electrolyte imbalances or metabolic acidosis. Interactions: ACE inhibitors, angiotensin receptor blockers, and direct renin inhibitors. Potassium supplements and salt substitutes, because remember, salt substitutes have potassium in it. So nursing considerations, once again, getting those baseline EKGs, weights, lab values, blood pressure, having them monitor their blood pressure, keeping a log of those. Instruct clients to avoid salt substitutes and potassium that contain potassium, and reduce their intake of potassium-rich foods, which is your oranges, bananas, and dates. Self-monitor blood pressure, blood sugar, and then have them bring those in to their appointment. Monitor for those endocrine effects. Then your osmotic diuretics, which is the last group. You have mannitol, this is going to reduce intracranial pressure and interocular pressure by drawing fluid into the vascular and extravascular spaces. This is a very potent diuretic that is only given by IV route. This prevents kidney failure, and it decreases intracranial pressure due to cerebral edema. It treats oliguria phase of the acute kidney injury, decreases interocular pressure, the ocular fluid, it makes it go back into the bloodstream, hyponatremia, and water excretion. It can also be used in the acute renal failure during prolonged surgery as well. So complications are heart failure, pulmonary edema. So you're looking for any signs, symptoms of heart failure, your dyspnea, weakness, fatigue, distended neck veins, weight gain, and just hold the medication and notify the provider. Rebound, increased intracranial pressure. So this is when you need to monitor for increased pressure. Level of consciousness, change in pupils, headache, nausea, vomiting are signs that you're going to look for. The rebound is they, discontinue this medication, and then the swelling comes back very quickly. It rebounds very fast, and it also could be worse than it was the first time around. Fluid and electrolyte imbalances, metabolic acidosis. So monitor lab values, monitor for drowsiness and restlessness, which is our signs of metabolic acidosis. Contraindications, obviously an active intracranial bleed, and urea, severe pulmonary edema, severe dehydration, and kidney failure. Precautions, anybody that has heart failure, pregnant or breastfeeding, kidney insufficiencies, electrolyte imbalances. Interactions are lithium and cardiac glycosides, which we will talk about in a couple chapters down the road here. Nursing considerations, mannitol by continuous, it has to be done by continuous infusion. You need to monitor for increased intracranial pressure, monitor for manifestations of the metabolic acidosis as well. Once again, your daily weights, I's and O's, electrolytes, EKGs, blood pressures, you need to all monitor that as well.